This lecture covers pulmonary blood flow and pulmonary ventilation. So when we talk about pulmonary blood flow, we need to note that lungs have two vascular systems, not one. The first is the pulmonary arteries and veins, which supply oxygen and nutrients specifically to the bronchial tree. The second vascular system is pretty much what we're going to be talking about this entire unit, which is the pulmonary arterial and venous system. And it's this system, this is the system that we're talking about when we speak of perfusion, which is the blood flow responsible for gas exchange. So every minute, in a healthy adult, about 5 liters of blood undergo gas exchange with about 4 liters of alveolar air. And this ratio, this 4:5 ratio, is an ideal ratio between alveolar ventilation and blood flow per minute. And it's specifically this ratio that is what this lecture is about. So ventilation is a common word in medicine, whether it's hyperventilating with anxiety or hypoventilating with sleep apnea or being on a ventilator in the ICU. We need to be as clear as possible what we're talking about when we're talking about ventilation and perfusion. So ventilation in the context of lung physiology is specifically about air movement into alveoli, specifically for gas exchange, or what we can also call alveolar ventilation. But what we do have to remember here is that not all of the air that we breathe goes directly into our alveoli, and that's why I've kind of divided it up into these 3 different terms here. So let's take a quick step back. So each tidal volume breath is about 500 milliliters. And if you translate this over 15, I'll put RR for respiratory rate, or 15 breaths per minute, you get about 6 liters total of air moved. Not all of this air is functional, but 6 liters of air moved. This air is made up of essentially 2 main components: dead space and alveolar air. So let's begin with dead space. So dead space per breath is about 150 milliliters per breath. And if we translate this times 15 respirations per minute, we get to about 1.8 liters of unused dead air that is moving back and forth in the conductive airways. And what I'm going to do is I'm going to round this to about 2 liters. So if we do 500 minus 150, that means that about 300 milliliters of the total tidal volume is used, reaches the alveoli and is used for gas exchange. And if we multiply this times an average of 15 breaths per minute, you get about 4.2 liters per minute, which we are just going to round to 4 liters. So just to summarize here, minute ventilation, or total air movement, is about 6 liters per average adult. Of that 6 liters, about 2 of it is not used, and about 4 liters of it is used, and it's this 4-liter number that we are specifically going to be talking about and referencing when we're talking about ventilation, or we can call it alveolar ventilation. And this will be alveolar ventilation in relationship to total perfusion. Perfusion, quite simply put, is blood flow to the pulmonary capillaries, and this is estimated to be about 5 liters of blood per minute. Or you can also think of it as the total cardiac output per minute that exchanges gas with the alveoli. So the ratio of ventilation to perfusion is about 0.8, and again, this comes from the 4 liters of alveolar air per minute mixing with 5 liters of blood per minute. But what we're going to find out is that ventilation and perfusion are not equal in all parts of the lung, and that ratio of V to Q changes depending on where you are in the lung. So to keep this simple, we're going to say that the ideal V to Q ratio is about 1. And this number, 1, is going to be used to gauge whether ventilation and perfusion are what we call matched or if they are mismatched. So let's see how the V to Q ratio can become abnormal. So when the V to Q ratio is less than 1, this means that there is a lower ratio of ventilation to perfusion. In basic terms, this means that blood flow to the alveoli is normal. Here, let's draw this really quickly. Here we have a nice alveoli, and here we have a pulmonary capillary. So we've got V and then Q. So like I was saying, this means that the blood flow to the alveoli is normal, and the alveolar ventilation is not normal. This means that something's wrong with the alveoli. It's keeping it from exchanging air efficiently. So an example of this might be fluid inside the alveoli that's keeping gases from diffusing efficiently. This could be something like pulmonary edema or pneumonia or mucus and emphysema. Or an extreme case, this might be a big peanut or something like that that's obstructing an airway. In all of these, gases can't normalize whatsoever, even though blood flow is normal. So whatever the case, ventilation is reduced, and the blood isn't able to pick up oxygen or dump waste products efficiently from the alveoli. So how does this affect the partial pressures in the blood? If there's poor ventilation in the alveolus, then alveolar partial pressure of oxygen is going to be lower, and the alveolar partial pressure of CO2 is going to be higher than normal. If this is the case, then arterial partial pressure of oxygen is also going to be low, and the arterial CO2 is going to reflect what's going on in the alveoli, which is also going to be high. Because the alveolar partial pressures, they can't be adjusted back to normal. They can't exchange gases. This imbalance of V to Q is found in normal physiologic tissue as well as with some common diseases. When V to Q ratio is above 1, this means one of two things. It either means too much ventilation or too little blood flow. Both really have the same effect, and the result is wasted perfusion. Gas is really going where there's no blood to make use of it, so it's inefficient. It increases physiologic dead space overall. And when we overventilate, we tend to, what I like to say is blow off CO2 quite quickly. And it also results in high arterial PO2. Let's draw a couple of quick alveoli here, receiving the same blood flow. So here we have ventilation, and here we have perfusion. So here we're going to give this person an anxiety attack. And in anxiety, you have a hyperventilation. Literally, you're hyperventilating, you're overventilating the alveoli despite, say, a normal perfusion. In our second example, we could have a pulmonary embolism or something causing a reduction in blood flow. It could be pulmonary hypertension, could be pulmonary hypertension from obstructive sleep apnea, for example. But here we notice that V is relatively normal. It can even reduce a little bit, but as long as that Q is quite low, there's still that ratio is still greater than 1, and it's going to result in these characteristics of the blood being low arterial PCO2 and high arterial PO2. Ventilation and perfusion have regional differences in the lung, and this can often dictate where certain diseases show up, as in tuberculosis and chronic obstructive pulmonary disease. Here the lung has been divided up into three main physical zones: Zone 1, Zone 2, and Zone 3. Zone 1 is the highest, and Zone 3 is below the heart at the base. Let's begin with ventilation. So ventilation in the apices is overall pretty bad. It's pretty poor, and two factors account for this. The first has to do with high pleural surface pressures on the upper regions of the lung. The pleural surface pressure is more negative at the apices than at the base. And you can think of the lung as being suspended from the top of the chest cavity, much like clothes on a clothesline. The area which is attached to the top of the cavity has the highest intrapleural pressure, and this results in pulling on the alveoli structures more. This leads to alveoli having larger volumes than at the base, and we can see that physically here versus all of these kind of small patchwork here. And it's smaller where the lung rests and is pulled down mainly by gravity. So this is the gravity-dependent section here. In the apices, the alveoli are more distended, they're less compliant, and they change volume less with each breath than at the base. So there's less of a volume change. I'm going to use V for volume here. So because of all these characteristics, the higher compliance, the less ability to expand, ventilation overall is pretty poor. That said, the alveoli at the base have much better ventilation as they're not subjected to the same forces. They've got normal compliance, they're surrounded by pulmonary vessels, and ventilation overall is pretty good. Perfusion in the lung has a similar course. In the more gravity-dependent base, they receive more blood flow, and really that's more blood flow per unit volume of the lung than the apex, or the apices. And blood really tends to pool here. And that pooling results in more distended pulmonary vasculature. More vessels are perfused, there's less resistance to blood flow, and gases transfer much more easier here. So clinically speaking, regions above the heart in Zone 1 have smaller capillary radii and poorer perfusion, which you can see in this illustration here. So we see this a lot in COPD, where air trapping really favors the apices. The alveoli, they're already distended, and hyperinflation of alveoli and emphysema can sometimes compress and pinch shut the pulmonary vasculature, ultimately cutting off perfusion. So what this does is this results in high amount of dead space, or at least the creation of more dead space in somebody with COPD. If we translate all of this to VQ ratios, in the gravity-dependent base, we've discussed how ventilation is moderate and perfusion is excellent. This results in a typical VQ ratio of less than 0.6. And again, that's because ventilation is good, but perfusion is outstanding. So that ratio is under 1. In Zone 2, this is where ventilation and perfusion are well balanced, and this ratio nears 1. At the apex, ventilation is poor, but perfusion is actually worse. So the ratio here is typically greater than 3. So to summarize, typically gas exchange is better in the lower regions of the lung because they receive more blood flow, and ventilation is far superior than in the apices. These ratios become more exaggerated the older that we get, and also with more types of, especially obstructive lung diseases. Here's an illustration of the spectrum of VQ ratios and typical reasons behind them. Let's start in the center with that well-balanced V and Q ratio of 1.0. On the left side, we're going to keep perfusion normal, but we are going to reduce ventilation. The big three that we need to be aware of that reduce ventilation would be fluid, obstruction, and fibrosis. So when alveoli encounter any type of fluid like blood, pus, or plasma, it reduces or obstructs the ability for gas to diffuse into the blood, for gas exchange. An extreme version of a disabled alveoli is an obstructed alveoli. Think of something like this, like a mucus plug. Or you can even think of a peanut lodged in a segmental bronchi. Or you can also think of fibrosis of the alveoli, which again blocks gas exchange or reduces gas exchange. When VQ reduces to 0, when ventilation is so poor that this essentially is a negligible number, we call this a shunt. And a shunt essentially is movement of blood flow from left side of the heart to right side of the heart without oxygenation. And this cannot be corrected by oxygen. This results in hypoxemia and underventilated alveoli. So let's move over here. Over here, ventilation is going to be okay, but perfusion is going to be terrible. This also is going to result in hypoxemia, but it has a different name. So once this has reached an infinity number, and again, that is due to this being so poor, this is what we call alveolar dead space. Dead space is typically found in the apices of the lung. It's found with a pulmonary embolism, and it's also found with pulmonary hypertension when these vessels are constricted. So something to know is going to be the VQ ratios and definitions of both of these terms, as well as common conditions that can cause both of them. So shunting, we've already discussed, is blood moving from the right to the left side of circulation without being oxygenated or exchanging any gases. Shunting does not correct with oxygen. And, it's essentially blood bypassing the alveoli because the alveoli are disabled, or if it's an anatomic shunt, it's because there's actually an extra vessel or some sort of a defect which is allowing blood to bypass the body. Let's go through some of these quickly. So an anatomic shunt would be something like a cardiac septal defect, and this occurs when blood moves directly from the venous to the arterial circulation without even touching the lung tissue. The intrapulmonary shunt is the pathological shunt that we've talked about in terms of pneumonia or obstruction, inhaling a peanut. So this is blood moving through the capillaries of an alveoli, and that alveoli itself is underventilated or totally unventilated itself. And to summarize all of these, the physiologic shunt is a combination of anatomic plus intrapulmonary shunts. And in some ways, this can be quantified in terms of volume, but we're not going to go through that in this lecture. So lastly, I want you to understand the difference between anatomic, alveolar, and physiologic dead space. So when a portion of the lung, or should I say the circulation to alveoli in a part of a lung are taken offline, this is called dead space. So this is the V over Q, where V is okay, but Q is terrible. This essentially is infinity. So anatomic dead space, like we've talked about before, is conducting airways that are not involved in gas exchange. Alveolar dead space, on the other hand, this is the more pathologic version where circulation is shut down despite a normal ventilation. And physiologic dead space is the summation of both of these two. And again, these can both be quantified in terms of volume, but we will not go into that in this lecture. So VQ for dead space is infinity. Alveolar capillary units have come up with an ingenious way to redirect blood from poorly functioning alveoli to better functioning ones. When ventilation perfusion is poor, resulting in low partial pressures of alveolar O2 and high partial pressures, alveolar pressures of CO2. This results in local hypoxia of the lung, which results over time in hypoxemia if it's significant enough. So blood flowing to this area will undergo little or no gas exchange. The lung has evolved to respond to poorly functioning alveolar capillary units like this, and it's called hypoxic vasoconstriction. It's been theorized that alveoli contain contractile cells that can distort their alveolar walls in a way that actually constricts pulmonary capillaries around them. When an alveolus is hypercapnic and hypoxic, these little contractile cells are triggered and blood is redirected away from poorly ventilated areas to better ones. So we can see the overall change from here to a contraction here, and this moves blood from here, and it redirects the traffic pattern down to better ventilating ones. So the result of this is taking a mismatch in VQ and creating a better match. And this is never perfect, but it improves the VQ ratio. The exact mechanism behind this isn't completely understood, but it seems to be a local release of vasoactive substances that are separate from the nervous system. The reason why we know this is because we see this in transplanted lungs. V and Q must be matched for optimal gas exchange. VQ ratios close to 1 result in alveolar partial pressure of oxygen being about 100 millimeters of mercury, while alveolar CO2 is about 40 millimeters of mercury. In ratios greater than 1, meaning that ventilation is excellent with poor perfusion, this tends to increase arterial oxygenation as well as reducing arterial partial pressures of CO2. With ratios less than 1, this does the opposite. This decreases arterial O2 and increases arterial CO2. We need to know the differences between shunt and dead space as being 0 and infinity. These are the extremes of mismatching. Let's remind ourselves of the regional VQ differences within the lung, and hypoxic vasoconstriction, when there are VQ differences, helps compensate for them.